All right. Well, Chris, thank you for inviting me to this candidate training. It's exciting to be a part of these campaigns. And I've been asked to talk about Medicare for all and also a national health system. So I wanted to start out a little bit, and I'll be mindful of the time.
All right, can I just begin?
I don't know. Yeah.
All right, well, Chris, thank you for inviting me to this candidate training. It's exciting to
Yeah, maybe like a headphone.
You're good now. That was my echo.
Yeah, okay.
Sorry.
All right. No worries. So I'm going to be mindful of the time, try not to speak for too long so that we can hopefully take some questions. So if you're watching this on another platform, YouTube or Facebook, whatever, yeah, I hope that you'll ask some questions. So I want to begin by talking a little bit about the healthcare crisis. I think it's important for candidates to be able to speak to that as well as the solution. And of course, the United States, in terms of all wealthy nations in the world, is the only one that does not have any sort of kind of universal healthcare system. We are the only nation really that treats healthcare as a commodity, as something to make money off of, as opposed to a public good or a human right. Like even other very capitalist nations recognize that you need a healthy population in order to prosper. So I think of it as an experiment. You know, there's been more than a century of efforts in the United States to try to create a universal healthcare system. And since about the mid 70s, 80s, when we really started to go in the direction of privatization, it's been really like an experiment, I think of, you know, like what is it like when you treat healthcare as a commodity? And the outcomes are very clear. One is very expensive. The United States spends the most of any nation per person per year on healthcare. We spend about twice what the average other wealthy nation spends per person per year. And remember that they have universal systems. They have better health outcomes than we do. We have about 30 million people who are uninsured, so no insurance at all. And then a similar number of people who are underinsured, and actually that's growing, of people who are paying a monthly premium for health insurance, but they can't afford to use it. So these are these high deductible plans that have become, as we've kind of predicted, that, you know, employers would start moving in that direction because they're less expensive for the health insurance company, for the person. They basically, you pay a premium, but before your insurance actually kicks in, you also have to pay a deductible, which is usually multiple thousands of dollars. Then your insurance will kick in, but then you still have co-pays and co-insurance that you have to pay part of. So even though you're paying a monthly premium, you're still paying, you know, thousands of dollars before your insurance actually, you know, provides anything. And so, so that's a huge moneymaker for the insurance companies because they basically have these healthy people, you know, paying their premiums each month, and then those who are sick are bearing the brunt of the cost. Also, health insurance companies are using these very narrow networks. So they restrict where people can go for care so that you're often stuck going out of network when you have a serious problem, or if you have an emergency and you get taken to an emergency room, may not be in your network, then you're stuck with the cost of that. So people with insurance that are still not protected. And because of that, well, two things. One is the high deductible plans, or even any plan that has a copay that you have to pay up front before you can get care, causes people to make a financial decision when they need care. And what the studies have found is that regardless of your level of education, of your socioeconomic status, people are not able to make a determination of whether the care they need is actually needed or not. So they, you know, they may decide, oh, I think I'm good, I don't need to go, and actually they did need care. And so this kind of, when people delay or avoid care, of course, that risks them having a worsening of their disease or symptoms, and then maybe needing more expensive care down the road when something could have been treated up front and they would have a better outcome and it would cost less money. The other thing is that this financial insecurity means that people are really at risk of financial ruin when they have any sort of accident or illness. And when we look at personal bankruptcies in the United States, the majority of them are due to medical illness. And about 80% of the people who go bankrupt because of medical illness had some sort of health insurance at the beginning of their illness. So having that health insurance was not protecting them from financial ruin. And in fact, there was a study that was done, published in the American Journal of Public Health in 2018, that looked at that when you factor in people's healthcare costs to their income, that due to healthcare costs, about 7 million extra people have been pushed into the poverty level in the United States. So the healthcare system is impoverishing people in the US as well. And for all this money that we spend, as you would predict, in a system where people can't get the care that they need regularly, we have poor health outcomes. We have very high rates of maternal mortality in the United States. We have relatively high infant mortality in some parts of the United States. The infant mortality is similar to what you would see in a developing nation. No excuse for that in one of the wealthiest nations of the world. Our life expectancy has actually been falling in the United States. So this is the crisis that we face, a for-profit healthcare system. Oh, and then the other thing is just the closing of hospitals. That's a big one. You know, we've lost since the mid-70s, although our population has increased significantly, we're losing hospital beds, because when you operate a hospital as a for-profit venture, and then you're in a community that's not generating profit for you, then you have an incentive to shut that down. And so we're seeing just a real epidemic of closures of hospitals in rural areas, and then also in urban areas that typically treat poorer communities. So Los Angeles, New York City, Philadelphia, losing their longtime institutions, hospitals that served low-income communities. So that's another crisis that we face. And with the pandemic, there was the big worry, right, is that we had all of these people that were becoming ill, and we didn't have enough hospital beds to manage them. And so there were people setting up these kind of hospitals and parking lots and convention centers and things like that. I think the pandemic was really good at pointing out a lot of the faults in our system. Another big one is the racial disparities in health in our country. And that is a systemic issue. And that's a whole nother talk about the racism that's ingrained in our healthcare system. But just to give you a sense, the Veterans Administration, which is a type of single payer, socialized medical system, when you look at health outcomes for people that are treated within the VA system, there is no racial disparity. In fact, in significant areas of heart disease where Black men in particular tend to have poorer outcomes than white men, you actually see that population, Black men in the VA system, having better outcomes than white people. So it's that racism is a systemic issue because of the way that our system is structured. So what's the solution? Well, in 2010, the United States Congress, President Obama signed into law the Affordable Care Act. That was not the solution. And it's important for you to know why, so you can talk about that. But there were all sorts of efforts used to prevent people from pushing for a national universal healthcare system and co-optation of progressive and labor organizations to back what the Democrats were putting forward, which was based on a plan that Mitt Romney passed in Massachusetts in 2006, which was based on a plan that was devised by the Heritage Foundation. So there's nothing at all progressive about the Affordable Care Act. What it really did was it expanded Medicaid to some extent in some states, but not every state, of course. About 13 states didn't. But it basically mandated people to buy private health insurance if you didn't have it. The government actually set up a market to sell that private insurance to people, and then subsidize to the tune of hundreds of billions of dollars a year the purchase of that insurance. And the whole idea was that they said they were going to create this competition that was going to drive prices down. Instead, the major insurance companies divvied up the country geographically, and people have very little choice. And so that competition didn't emerge, the prices didn't go down. And this just ended up being a huge transfer of public dollars into the hands of the private health insurers, who have seen record profits since then. And then it also fueled this merger, this consolidation of our healthcare system. So in order to have any kind of market power, we see these big health systems gobbling up, and even insurance companies. Aetna bought CVS. We have insurance companies that are doing what's called vertical integration. So they don't just own one part of the system. They provide the insurance, they own the hospitals, they own the practices, they own the laboratories, they own all the different components. So they're making, money every which way. And this consolidation and corporatization of our healthcare, where in fact, venture capitalists are now owning these parts of our healthcare system and profiting off of it. I think a third of emergency room doctors, and many hospitals contract out to private corporations to provide staff their emergency rooms. A third of them are actually in companies owned by KKR and Blackstone. So they're making all this money off of our healthcare system. And so it's this kind of corporatization and consolidation, monopolization of our healthcare system since the passage of the Affordable Care Act that has created, as I will talk about in a little bit, the conditions in which a national improved Medicare for all is not going to be the ultimate solution to our healthcare crisis, although we still are advocating for that. Ultimately, we are going to have to create a national health system, and I'll get into that in a moment. So I'll start out with National Improved Medicare for All. This is kind of a proposal that has been supported by a strong movement nationally for a number of years now. The first 21st century piece of legislation that had this was 2003, John Conyers HR 676, which was a piece of legislation that was based on a proposal put together by physicians with the Physicians for National Health Program, a national health policy organization. And then that legislation ended with John Conyers. 1 second. What do you need, sweetheart? Okay, I'll have to wait just a minute. Okay, so that piece of legislation ended when John Conyers left office, and he since has passed, unfortunately. But National Improved Medicare for All is a system in which every single person living in the United States would be put immediately, all at once, into a national Improved Medicare for All healthcare system. So you would automatically be enrolled. If you showed up at a health facility and you didn't have a card, you were assumed to be in the system. You would get your treatment first. They would sort out the enrollment later. So the opposite of what we have right now. It would be comprehensive, covering all medically necessary care as determined by a health professional and the patient. Patients would be able to go anywhere in the country. So if you're traveling, whatever, if you have an illness and there's an out-of-state facility that specializes in that, you can go there, no questions, no barriers to that. People would have free choice of health professional, and it would be paid for upfront through progressive taxes and using the healthcare dollars that we're currently using. And so there would be no copays, no deductibles, no financial barriers that would keep people from getting health. So that's kind of in a nutshell, that it's national, it's nationwide, it's improved because current Medicare doesn't cover, things like hearing and vision and dental care and other things that are necessary. So it would be an expanded and improved Medicare type of system and for everyone. And that was thought to be the simplest thing, is that we would keep all the providers the same, but everyone would be in the system, the government would pay those providers. And in fact, as part of that, which is really important, is that the system would use a system of paying for operating expenses. So every facility, I will as soon as I finish my talk, okay? Every health facility would get a global operating budget that they could use, so you wouldn't have to worry about, billing for every Band-Aid and every alcohol wipe. You just focus on treating your population. You're getting the money to cover your facility, cover the supplies that you need, cover the people that work there each month. And then separately, if you needed to expand for some reason or purchase some technology, then that capital expense would be separated out, so that there could be some control, so that you wouldn't have one hospital getting a certain technology and then making a lot of money off of that. And then hospital, down the road is like, well, gosh, we have to get one of those. And that's a huge waste of money. If you already have one in the community, you don't need to have every hospital having the same technology. We would move towards what we call centers of excellence, in fact. So that's National Improved Medicare for All. And there is legislation now in Congress that's somewhat similar to the John Conyers HR 676, but differ in important ways. And one is in the House, we have legislation from Pramila Jayapal. She's a congresswoman from Seattle, Washington. And Jayapal we tried to get her to take HR 676 and just submit that, but she wanted to create her own piece of legislation. And in terms of, coverage and things like that, it's pretty good. I would say even good in terms of the language that anti-discrimination language is pretty good, but it has two what I think are very significant weaknesses. One is that it would not buy out the for-profit health facilities in the country, and it would allow them to continue to operate in the system. And the big problem with that is that the way that this legislation would control those would be to, again, you get this operating budget, and this is what you have to work with. So what these for-profit entities are either going to do is they're either going to skimp on the care that they provide, like we see in these for-profit kidney dialysis centers, like DaVita, where they don't even clean the equipment properly. They don't give people a full treatment because they want to churn them through. So you would see this kind of substandard care, or you would just see them leave. They'd be like, well, we can no longer make a profit, so we're going to sell this building for commercial or residential, like what happened to Hahnemann Hospital in Philadelphia, where it was going to be turned into, I think, residential and shopping space, because that would be a lot more profitable. So we need to buy these facilities out and not allow them to continue to operate as for-profit, so that we can maintain that infrastructure that we need, because we need to build even more health infrastructure in this country. And then the second thing that's a big flaw with the Jayapal bill is that she would phase it in over 2 years. So the first year would be, I think, everyone 19 and under, and then everybody, I think, 55 and above, which is about half of the US population. There's absolutely no reason why we would, cover half of the population 1 year and then add the second half the next year. It makes absolutely zero sense from any standpoint that I could think of. And we argued this with Jayapal's office for quite a while. And the only thing that they could come back with was, well, Sanders' bill has a 4-year phase in, so we're doing a 2-year phase in, and that sounds better to us. But the reason that National Improved Medicare for All works is that when you have everybody in the same system, then your administrative costs go way down. We would save hundreds of billions of dollars. I've seen anywhere from $450 billion to like $750 billion a year in administrative costs from having one system, one set of rules, one process would greatly simplify things, and that saves a huge amount of money. But when you're phasing people in, you're still continuing to have this new system, and the old system is very complicated. Doesn't make any sense. So those are two big pieces of criticism of that piece of legislation. Senator Sanders just introduced a bill, a Medicare for All bill, on May 12th. That was after a lot of pushing against him to do it. I could not find a text of that legislation, but if it's the same bill that he introduced after his presidential run, it also has pretty significant flaws. And one big piece is it also allows the private health entities to operate. It doesn't give a global budget, so there's no way to actually kind of regulate those industries. And it has this very complicated 4-year phase in. It was basically what Sanders did, because we tried to meet, well, we did end up meeting with his health staffer, and she actually didn't have a health policy background. So that was a big impediment. And she didn't like the fact that we weren't Democrats when we were talking to her. And we kept kind of pushing on Sanders. And in the end, what he basically did was he farmed out the legislation to other senators who wrote in their pieces of the bill in order to be able to be a co-sponsor, be willing to be a co-sponsor of the legislation. And Sanders wanted to have a good number of co-sponsors when he rolled it out. So he ended up sacrificing policy for that. And the bill is a real kind of a hodgepodge. And I think it's designed to fail quite literally, quite realistically, is that when you create this very complicated rollout, it's not going to work. And so people are going to basically say, this doesn't work, it's not good, I don't like it. And by the end of the 4-year period, I think there's going to be very little public support for that piece of legislation. So that's kind of what we have, the situation in Congress right now. And of course, despite the pandemic, there's really been no movement on the pieces of legislation. In fact, President Biden campaigned openly against improved Medicare for all and said even if Congress passed a bill and brought it to his desk, he wouldn't sign it. So that's kind of that environment in Congress. But should we even be advocating for national improved Medicare for all anymore, given the corporatization of our healthcare and the dominance of the corporations over our Congress? Wouldn't it make a whole lot more sense just to cut them out completely and have like a VA type of system? There have been attacks on the VA for quite a while. There are efforts to privatize it and kind of chop it up, which are ongoing. So there's a lot of kind of bad press about the VA, but when you actually look at how the VA operates, it's less expensive. As I said, it's more equal, and they have better health outcomes. And the VA doctors that I know are pretty happy people because they're provided with factual information about things like pharmaceuticals and treatments. They are given the latitude to treat their patients without insurance company hanging over their head and telling them they can't do certain things. So they're able to just really focus on treating their patients, and their salary. So they just, they know they have a guaranteed income. They can just focus again on practicing medicine. So that's the VA system. And that's, I think, where we really need to be moving. And when Howie Hawkins was running for president, he and I drafted a health policy platform. And I recommend that you check that out, HowieHawkins.us. And if you go to issues, you'll see Medicare for all. And basically what we said was, let's immediately expand to Medicare to everybody. That's something that we could do tomorrow. Every single health professional in the country has a national provider identification number. And so every physician, even as a pediatrician, I had one of those numbers. And so we have a way to pay every single health professional in the country already, if we just expanded the Medicare system and improved the benefits of that. But then we really need to move, as I said, towards a national health system. And what Howie really advocated for, and I support as well, is a community-controlled national healthcare system. So, all health facilities are owned by the government, but they're set up and run by members of that community so that they have a say over what that hospital or facility provides, how the care is given. So, there may be issues of making sure that we provide culturally competent care in certain communities. So basically, each community is a little bit different. How do they have a mechanism to have input to say what their health facility, how it best serves their community? In terms of, so we basically called for an immediate expansion of Medicare to every person, to immediately get rid of the private insurance industry. They're just a money-making venture that is obstacles to getting the care that we need. And then start to create a national database so that we actually have accurate information about what's happening in our country. We don't, because a lot of private corporations keep that information as proprietary. In fact, a number of years ago, the Center for Medicaid and Medicare Services was going to require these private Medicare plans, they're called Medicare Advantage plans, the private ones, to release their data on how their healthcare dollars are being spent. And the researchers, were all like very excited about, we're finally going to get to see how this money is being spent. And of course, the insurance companies lobbied, the CMS put pressure on them, and they didn't force them to release that. So we still don't know how they're spending our public dollars. So creating a national database would allow us to have real-time information about outbreaks and health problems and maybe outliers and things. Okay, I'll plug it in just a minute, sweetheart. And then where was I? Oh, shoot. So then after creating a national database, Also to create a national mechanism where we have feedback about what the healthcare needs are, so we can start prioritizing. We need to build hospitals, especially in low income and rural areas. We need to attract, health professionals to certain areas. We don't have enough primary care physicians. They are the backbone of a good healthcare system. So how do we make sure that we're training and getting the primary care physicians into the communities that need them? That would all happen immediately. And then over 10 years, we would phase to a completely publicly owned and publicly operated, transparent and accountable, democratically run national healthcare system. So that's where we need to go. And I think what I'll do is stop talking there and see, Chris, if you have any questions, or there's a couple other folks that are on the Zoom, or anybody on YouTube who might want to put a question into the comment area. I'm happy to respond to any questions. Thanks.
Yeah, one thing I want to bring up that, COVID exposed our healthcare system in a lot of ways, a whole lot of ways. But one thing that I noticed was, and I bring it up because it really hits on the private profit aspect of this. Our medical infrastructure wasn't prepared for a pandemic. So what happened is basically vultures came in and formed testing companies. And, I was reading about one out of Chicago recently that, they literally tens of thousands of tests they just trashed. While the owner was posting pictures on Instagram of his of the Lamborghinis he was buying, right? And then that's the one I drive past it every time I take my son to his grandparents, right? That's the one that sits in that parking lot. And so, when something like this does happen, we're setting ourselves up. It's just getting exponentially worse, right? Because we're not able to prepare to do it. So this is America. So we go, the private market will cover it, but the private market didn't cover anything but enriching themselves. And reading that article, they were getting $300-400 a PCR test.
Wow.
From the federal government, right? Wow. So it was not a small amount. And in that company's case, like, to give them a little, to take my heat off them a little bit, I do think they got hit by that winter surge we just had over the holidays. And they went from 10,000 to 50,000 tests a week, and they just couldn't handle it. Yeah. But they took that money and they trashed those tests. So,
Yeah. And if you remember in the beginning, and this is, so the countries that did the best in handling the pandemic are countries that were able to have central planning and a national strategy for dealing with the pandemic, which we didn't have at all. And so you literally had hospitals within communities and states battling each other for the limited supplies that we had. And so the private companies were just like, oh, wow, protective equipment, there's a high demand for this. So they're like selling it to the highest bidder, right? So there's bidding wars are going on, these clandestine, taking like trucks that are labeled for something else and trying to sneak the PPE into
yep. I know our comptroller had a staffer with a check for millions of dollars meeting a truck driver in a McDonald's parking lot as they were crossing through the state, because they were worried another state was going to drive there and give them a check for millions of dollars first.
Yeah.
Right. That's no way to run a system.
No. It was worse than I even imagined that it could be, but it did in so many ways. The pandemic has exposed the flaws, and unfortunately, so many people that have died that shouldn't have died as a result of that. I think somebody asked in the chat, what is one of the hardest questions that you have? Other than coming up the kind of the typical or the hardest obstacles you have to selling this. There's all of this misinformation, of course, in the corporate media about what National Improved Medicare for All is. And, they call it socialism. That's a big thing. You're talking about socialized healthcare? Well, no, we're talking about is what every wealthy nation basically does, because health is a public good and not a commodity. And when you treat it as a commodity, people die and suffer, and we all suffer as a result of that. So I say it's civilized healthcare is important. I think the big thing is rationing. They always point to, oh, well, now the government is going to be rationing the healthcare. We already ration healthcare in this country. We ration it in the cruelest way possible based on ability to pay. No other nation, does that. And then thirdly, they'll say, well, innovation is going to suffer if you don't have market-based healthcare. Well, you can look around the world and just see that, no, that actually doesn't happen. Many other countries do excellent research. I mean, look at Cuba, a poor nation under an economic blockade for more than 60 years, and they have amazing medical breakthroughs down there that we don't get to benefit from because of the economic blockade, and we can't share that technology. But what we currently have in this country is a system where even the research is based on profit. So like when it comes to pharmaceuticals, they're just trying to do the easiest thing they can do. Take a current medication, tweak the pharmaceuticals, the chemical structure a little bit, repatent it under a new name. It doesn't have to be better than what we already have out there. And, market that, as opposed to looking at what are our needs, what should we be funding, what do we need? And then, if there's certain things that just aren't that profitable to make or sell, basic medications that we need, the pharmaceutical company is like, oh, we're just not going to make it anymore. So when you have a national health system where those federal dollars are being used to prioritize what we need, you get the kind of innovation that we actually need, which is addressing the real issues that we have, and not all this kind of wasted money that's not actually improving our care. Same thing with medical devices. We have all these medical devices. A lot of them don't even do what they say they're going to do, but companies are just making them and then marketing them to physicians, hospitals, to make money.
It always makes me think of the Lyme disease vaccine.
Mm-hmm.
It exists. There's a way to stop people from getting Lyme disease, a debilitating disease, but it wasn't profitable.
Yeah.
So it got pulled.
Yeah.
There's a question from YouTube. Can you talk about the ongoing hostility of many institutions and orgs to Medicare for All, U.S. unions, Planned Parenthood, or U.S. unions, for example? Also, groups like Planned Parenthood and Consumer Reports seem to feign neutrality, but it's not hard to take their silence as opposition.
I think, yeah. So I think it's important to begin by recognizing that the public in the United States is really with us on this, and that poll after poll has shown that the majority of people in the United States want a public healthcare system. That even what we're seeing, interestingly, is more people who identify as Republican and conservative coming on board and supporting this. And I found that in my own conversations with folks over the years when I was out, and there were counter protesters. And so there is that. But of course, for the major labor unions, a lot of them have their own health plans. And so it's an economic issue for them, where they are, they have all these people that are running those plans that are making pretty good money from those plans, and they don't want to lose, those jobs and that income. So I think that could be kind of some of their opposition, as well as the fact that, not all labor unions are progressive. It's a very mixed group of people in the United States. I think that in terms of like some of the nonprofit organizations, there's a real tie to the Democratic Party, which is something that I saw, and so a lack of willingness to come out and go against, an administration that's hostile to this right now, and a Congress that's, does a little bit of lip service, but is really doing nothing to advance this issue, despite economic crisis and healthcare crisis in this country. So there is going to be that opposition. But again, we have to remember is that if we organize and create that visible wave of support and make that demand, these groups are going to come on board because they're going to have to. They're going to look bad if they don't. So I wouldn't worry about that so much at this point.
Yeah, we had our Pride here yesterday. We do a festival instead of a parade, and we do it in May because we're close enough to Chicago that if we tried to conflict on the traditional Pride weekend, no one would be here. Mm-hmm. The organizations, the table wouldn't be here. The people would drive to be with 1 million people in Chicago instead of a few thousand here. But in 2016, we had a table and we're petitioning, and we were next to Planned Parenthood. And we were setting up, and I, put all of our stuff out, and the Planned Parenthood volunteers started asking me where we stood on abortion. And I told them, well, we're for full access, no questions asked, fully funded under a national, under Medicare for All. And I mean, their jaws dropped. as volunteers, and they're like, there's a political party, that supports this. And they all signed it. I got 750 signatures, 700-ish signatures in one day.
Wow.
Because they had a little game where you spun and you got, a free prize. And there's just a line there of people who support Planned Parenthood. And I'm walking the line. Just, do you support abortion covered under Medicare for all? No questions asked, fully funded. Yes. Signature, 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 signature.
Wow.
So it's like Democrats, right? The people support it. The organizations might not, but the people do.
Right.
And, one thing with Planned Parenthood that I was talking with somebody about was during 2020 when we put forward that plan, was them trying to wrap their head around our plan that Planned Parenthood wouldn't exist anymore. And they had this real trouble of like, how I want it to always exist. It's like, but it won't need to fill this role because it will be filled within the medical service or the medical system.
Yeah, but at the same time, you could see
the same exact
keeping those facilities, because you still need maternal and pregnancy care and people that are going to want to terminate pregnancies. I mean, that.
Yeah, it was someone.
Why couldn't they come into the system?
They volunteered for years and they just had this attachment to the organization. And the thing with unions that always shocks me is, in union negotiations, healthcare is like the number one thing they're debating.
Right.
Like taking that off the table means they get to talk about cost of living, they get to talk about raises, they get to talk about
worker safety. Conditions. Exactly.
Like that, all the, not to say healthcare is not important, but all these really important actual workplace, things that unions need to be advocating on.
Plus striking. What's the biggest thing that the employers do when workers go on strike? They pull their healthcare.
Yep.
Right. So, that it takes away that leverage.
So I know you've got to go real quick, but Matthew Ho wanted to know, are there any resources you can recommend, authors, websites, so that people can consult data, information, and advocacy for universal health care? So
Physicians for National Health Program, and disclaimer, I'm an advisor to the board. PNHP.org is actually a really excellent resource. They have they're posting new articles all the time on what's going on, as well as they have just basic resources about what this is and studies that people can cite. For a while, and I just haven't been able to keep it up the way I want to lately, the Health Over Profit for Everyone campaign, healthoverprofit.org, but we created activism tools as well as education tools there. So people can still access that website and get those handouts and basic information there. But I think, what's kind of disappointing in terms of like where the movement is right now is that there are kind of these long-term groups that are not willing to push the Democratic Party. And then we have this new energy that's coming in. March for Medicare for All is one of them. And they're really trying to push for this in a way that's, what needs to be done. I think, it's like we're not, some people unfortunately have a strategy like, if we're not going to get Medicare for all until we elect enough progressive Democrats. And what the reality is we're not going to get Medicare for all until we form a national movement that makes that demand. Hey, so
it's mine.
Yeah. July 30th is the next March for Medicare for All.
It's Medicare's birthday. Yep. And that's going to be nationwide. And there's actually on Popular Resistance, I have information about that. Sweetheart, unfortunately, this is the wrong one, but I'll plug it in just a minute. Okay, I'm almost done. Sorry. I was letting the kids use their tablets while I was doing this.
No, you're good. As a parent and a former preschool teacher, you're good.
And he already took his bath and got ready for bed because, I don't know, it's hot. He wanted his bath early.
Well, I'm planning to try to organize local on July 30th with that.
Great.
I know the Illinois Green Party was one of the key organizers in Chicago as well. And that, like you've said, with pushing the Democratic Party, that's what that movement, that budding movement is running into.
Yeah.
Right. That Chicago movement, that Chicago event at their last national, day of action had really no official Democratic support and almost no kind of front group not-for-profit support from the people who support this. But, you know, Biden said he wasn't going to pass it, and they were still in anyone but Trump mode. And, you know, anyone but Trump's still very alive, even though he's not in office.
Right, right. But don't let your young child unplug your cord.
Do you have any, I know you got to go. Do you have anything to close?
I think that every single person can advocate for this. I think some people get hesitant because they get convinced that healthcare is complicated and that you have to be some sort of policy expert. And the reality is that it's not complicated. It's very simple. And don't let people kind of try to befuddle you in any way. You know, learn what you can about the basics of the program and go out and advocate for it. And you will get questions that you don't know the answers to. Don't stress about that. Go and find the answer. So the next time, you know, you can handle it, or just say, you know, that's really interesting. I haven't really thought about that. I need to go do some research on that. So yeah, don't let folks kind of beat you down and make you think you can't get out there and advocate for this. Everybody can understand the basics of health policies, just not that complicated. And yeah, so don't be afraid. Have courage, get out there, speak loudly. And yeah, that would be and I'm also available if folks, you know, need assistance. Get in touch with me, and you know, Chris knows how to get in touch with me. But yeah.
Yeah, and I've got to say, from past experience, Physicians for a National Health Program has great resources. Like pnhp.org has workshops and, you know, presentations that you can download, read the information, then put on our Medicare for All presentation at your local library, where you've got all, you know, it's already made for you, and a lot of the work's been done. So we have a local in Peoria, Illinois, that really focuses on Medicare for All, and every time PNHP comes out with a new workshop, they present it. So yeah, there's definitely resources out there, and that's a great one.
And you don't have to be a physician to be a member of the organization. So it's or even a health professional to be a member. So.
Well, thank you so much for coming on, Margaret. It's always great to talk to you. It's always great to hear you talk about this super important issue. This has been part of the Green Socialist Organizing Project's campaign training series that we've been doing for the last few months. You can go to greensocialist.net/campaign-trainings to find recordings of past ones. In April, we did campaign systems and Green New Deal. In May, we did petitioning and then this Medicare for All. Next month in June, on June 5th at 7 p.m. Eastern, we've got media and social media presented by myself and ILGP co-chair AJ Reed. And then on June 26th at 3 p.m. Eastern, we're going to be talking peace and anti-imperialism with Matthew Ho, who joined us for this. So those are great, you know, events coming up. Like I said, you can find information about those at greensocialist.net/campaign-trainings. The other thing I want to plug real quick is another project that's been coming out of the education working group that I work with in the Green Socialist Organizing Project, is we do a recurring series of 101s. We're the Green Socialist Organizing Project, so we go Green Party 101, Socialism 101, Organizing 101, Green Party 101, Socialism 101, Organizing 101, and we repeat and we refine, and they're onboarding and also informational. But Tuesday we will have our second Socialism 101. That is Tuesday the 24th at 8 p.m. You can go to greensocialist.net/101s with an S to register. And that's presented by myself and GPUS co-chair Garrett Wasserman. So you can go to greensocialist.net and check out all that stuff and all the work that our education working group is doing. And again, thank you so much, Margaret, for coming on and doing this. Sorry for the technical problems that got us started a little late, but we will be in touch soon, and thank you for everybody for joining us.
Thank you.